Bismillah ar-Rahman ar-Rahim. I will speak about a very important subject which is dysfunctional breathing. Definition. Dysfunctional breathing encompasses a range of breathing pattern abnormalities with breathlessness and over-breathing in the absence or in excess of any physiological abnormality. Hyperventilation syndrome is a form of dysfunctional breathing and the terms are often used interchangeably. Dysfunctional breathing may occur as a part of a spectrum of physical symptoms such as chest pain, palpitations, tachycardia, fatigue, dizziness, paresthesia, headache, diarrhea, inappropriate sweating, from an anxiety or panic disorder. Other specialties may have been consulted due to the mixed symptomatology. Pathophysiology. The dysfunctional breathing can occur de novo or follow a respiratory disorder that has resolved, such as a respiratory tract infection or as a result of chronic respiratory conditions such as asthma. It appears to be based on heightened awareness of breathing and concerns as to what the shortness of breath signifies. The PaCO2 is intermittently low with a respiratory alkalosis. Recording of breathing pattern often show a rather chaotic pattern. The clinical features of dysfunctional breathing include the following: intermittent episodes of breathlessness, largely unrelated to exercise, although can be worsened by exercise. It may be associated with symptoms of respiratory alkalosis such as numbness, tingling of the extremities, feeling of impending doom, and lightheadedness, occasionally to the point of losing consciousness, such as cerebral vasoconstriction due to hypocapnia. Sensation of not being able to take a satisfactory breath. No history suggestive of an alternative current respiratory disorder, although there may have been one previously. History of some stressful situation in the patient's life and the previous episodes is, are present. The diagnosis of dysfunctional breathing. The diagnosis is essentially one of exclusion, but with additional confirmatory findings. No evidence of respiratory cause, normal lung function, normal chest radiograph, normal saturation of oxygen at rest and on exercise to the point of breathlessness. Note better that saturation of oxygen may even rise on exercise. There is no evidence of a cardiac cause for the breathlessness. There is a regular breathing pattern at rest and on exercise. Can be detected by watching the patient exercise often, which often reveals almost instant shortness of breath and shouted breathing. No evidence of pulmonary hypertension. No evidence to support thromboembolic disease. No evidence of hyperthyroidism. Low PCO2, raised pH on blood gases, and a normal AA gradient. No metabolic acidosis on blood gases, such as ketoacidosis or lactoacidosis. Unresolved psychological issues or social phobia or agophobia or agoraphobia may be present. The Megan questionnaire has a good positive and negative predictive value for diagnosis of hyperventilation syndrome. The Megan hyperventilation score, it is a score which filled in by a patient and include the following items, which include the following items, asking the patient before treatment about chest pain, feeling tense, blurred vision, dizzy spells, and feeling confused, the faster or deeper breathing, shortness of breath, and tight feeling in the chest, and the bloated feeling in the stomach, and tingling fingers, unable to breathe deeply, stiff fingers or arms, tight feeling around mouth, cold hands or feet, heart racing, which means palpitations, feeling anxious. And while asking that points, give scores when never or rare to occur or sometimes to occur or often occur or very often to occur. And this point is started from 0 to 4. 0 at never and 4 when very often. Then collecting that score, and if the score, the final or total score, more than or equal to 22, it is highly suggestive of hyperventilation syndrome. Management of hyperventilation syndrome include the following. It's important not to dismiss the patient's symptoms, implying it is all in the mind. The patient has a real symptom which may require a real explanation. There is no controlled trials of the management, but most clinicians will offer an explanation based on an over awareness of respiratory sensations occasioned by some previous respiratory illness, heightened by an anxiety. It is important to explain that the associated symptoms of the tingling and lightheadedness are well recognized and harmless. Review by an experienced respiratory physio- physiotherapist and control of breathing exercise may be useful. Careful and convincing explanation without over investigation may be enough, stressing the normality of the investigations. A short period on an anxiolytic, as for example diazepam 2 to 5 mg twice daily, may be helpful to demonstrate that the symptom can be controlled. Management of psychological problems may be possible. Failure to respond should always prompt a reconsideration of whether an underlying disorder is gradually progressing to the point where an investigation becomes abnormal. On the other hand, repeated investigations will confirm the patient concerns that the doctors think there is something wrong. The prognosis of dysfunctional breathing, some patients improve quickly with explanation of the underlying condition, and some tend to relapse at times of stress, and some prove resistant to any treatment and properly should be seen in the clinic regularly but infrequently to reduce their likelihood of involving other medical services with another pointless round of investigation. That's all about dysfunctional breathing. Thank you.